to see each other this way.
Yeah, and we get to see each other more often now.
That's probably true. That's
Yeah.
probably true. Yeah,
So we
absolutely.
have one with you today, and we have one more, which is in the month of December, I think.
Oh, good.
Yeah,
Good. You guys have done a great job organizing so many things for your members.
yeah.
Yeah, it's a challenging year for sure, but the education is there.
Thank you so much. Thank
Yeah,
you.
the education is there. So I've tried to keep this both basic with a little bit of advanced things, but you know, basic.
Ma'am, we are live.
You know, try to keep some basic stuff for the audience.
Okay, so I
We are
welcome
live.
everybody. I welcome everybody to this AIOS Masterclass on managing posterior capsular rupture. And we have none other than Dr. David Chan with us. It's very difficult to find time from him, and we've been, after him for last 2 months to give us time, and he's been really busy, but we are thankful to him for having spared his valuable time. Dr. David Chang, of course, needs no introduction. We know him all very well for people who travel to ASCRS, ESCRS, American Academy of Ophthalmology. He's graduated from the Harvard College, and he's got his medical degree from Harvard Medical School. He's taught cataract surgery to ophthalmology residents in training for more than 35 years now. And he became only the third ophthalmologist to receive the Charlotte Bear Award, honoring the outstanding clinical faculty member at the UC SF Medical School. Dr. Chang has received the highest international awards for the cataract surgery from American Academy of Ophthalmology, which is the Kelman Medal Lecture, and from the international various other international cataract and refractive surgery societies. So there is a long list of awards: the Binkhorst Medal from the American, the Ridley Medal from the European, the Award of Excellence from Canadian Ophthalmic Society, and then from UK and Ireland, Rayner Medal; from Germany, the Doc Innovator Lecture. He's been to our conferences as well. The Gold Medal from the IRSI and the Asia Pacific of Cataract and Refractive Surgery, the Limb Medal. He served as a president in 2012, 2013, and he's on the executive board of American Society of Cataract and Refractive Surgery, the largest international organization for the cataract and refractive surgeons. He co-chairs the ASCRS Foundation and received the prestigious AAO Humanitarian Service Award in 2019, and he has been honored by the various international ophthalmic associations and society. He's authored 5 best-selling textbooks on cataract surgical techniques for ophthalmologists, and he's been named in every biennial list of the top 100 most influential people in ophthalmology as voted by the international readership of the ophthalmologist. Dr. Mahipal Sachdev is the moderator with me, and he's going to be joining in very soon, the president of All India Ophthalmological Society. We have other panelists with us, Professor J.S. Tityal, who's the head of the Cornea, Cataract and Refractive Surgery Services at RP Center, All India Institute of Medical Sciences, New Delhi. Dr. Partha Vishwas, who's the chairman, scientific committee of AIOS and director, BBI Foundation at Kolkata. Dr. Arup Chakravarti, who is the editor proceedings of All India Ophthalmological Society and senior consultant from Chakravarti Eye Care Center, Trivandrum. And Dr. Rajesh Sinha, the treasurer of All India Ophthalmological Society and professor at Cornea, Cataract and Refractive Surgery Services, RP Center, AIMS, New Delhi. So with this, we would move to the master class, which we all are waiting for. And I would request Dr. David Chang to give his talk on managing posterior capsule rupture.
Well, thank you for the introduction. Just to confirm, you can see my screen now. And I am delighted to have a little more time today to talk about posterior capsule rupture. And this will be our first, it'll be a series of videos. So here I'm doing a CCC and a patient with posterior polar cataract. And you want to mentally rehearse what are the steps that I'm going to take if I discover posterior capsule rupture. You hydrodelineate, you do not hydrodissect, but even before doing these cases, you know that, okay, I may have a posterior capsule rent. What are the steps? And of course, the very first thing is, if I encounter that, don't panic, but I have to stabilize the anterior chamber when I come out, so I don't have vitreous prolapsing through the defect, and so that I don't expand the rent too much. My approach to posterior polar cataracts is, if I can, I try very hard not to rotate the nucleus, because that is the kind of pressure against the capsule that will not only puncture it, but also extend it from a small opening into a very large opening. So here you can see, using horizontal chop, I'm trying to advance the pieces to the middle of the eye and to not rotate. But try as I can, it's difficult, and you'll see I am doing rotation here to mobilize the epinucleus, even though I would have preferred not to. And it's just a bit denser here. So now that I have to lift this up, I'm going to be trying very hard to pay a lot of attention to the posterior capsule. And the minute, if I see anything, again, I've gone through the mental steps, I've rehearsed what I'm going to do, I'm going to stop, and I'm going to reach for a viscoelastic in my left hand. It doesn't matter what viscoelastic I use, because I don't have time to think about or open a new one. I'm just going to say, open the viscoelastic. Now, here I'm starting to see the posterior capsule exposed, and I'm going to see if you can tell with the video. It looks good here, but then I see an edge. I see an edge right over here, and I'm going, darn it, So here I inflate. I go to position 0 on the phaco tip. Then I come out. So you have to go to 0, because otherwise you'll flush out all the viscoelastic. And then I change my illumination, and here you can see the outline. Now, in this situation, my goal is to avoid vitreous prolapse. And biaxial INA is very helpful, because you can see that I can reach across the chamber to the opposite end. I can occlude the tip, but I can dissociate the irrigation and the aspiration. My aspiration is behind the capsular axis. My irrigation is way up high in the anterior chamber. And I'm trying not to point the irrigation toward the opening, because the hydrostatic pressure is going to open it up. Now, as you know, to switch hands, I've got to do the same steps. I've got to block, fill the chamber, pressurize it, turn off the infusion. Now I can come out and switch hands and stabilize it. This is the other advantage of biaxial INA, is I can get to the subincisional cortex. I can again dissociate irrigation, aspiration, keep that up high. And so my goal then is, again, to avoid rupture of the vitreous hyaloid face. And there we are. And then I'm going to, again, every time I do this, I have to pressurize the anterior chamber with viscoelastic, go to position 0, come out. And what can I do now? How many people would put in a one piece in the bag? Well, you could, but it's tough. So the safest, in my opinion, a 3-piece acrylic into the sulcus. This happens to be the AR40 from J&J. It's acrylic. I dial it in. And then by capturing the optic, we don't have to change the IOL power. We don't have to worry about rotation, decentration, but most importantly, we block that opening. And the viscoelastic that's in there will go through the opening into the hyaloid space and get reabsorbed, so we won't have an IOP spike. So I don't go and try to aspirate that. But you see how here, when I take out the viscoelastic, it's safe, because I have essentially blockaded that opening. And then you can see the capture and the opening. Well, let's do another posterior polar cataract here. This one is, again, pretty dense. Unfortunately, the nuclei are pretty soft. This is Zepto. which guarantees a perfect capsulotomy. It's just using electrical energy so rather than a femto, and femto, you don't want to do femtonucleotomy because the air bubbles could rupture potentially. Let's see, my video is not playing here. Okay, so then I'm going to retract this. And I don't want to hydrodissect, but hydrodelineation is okay. So there's the opening in the anterior capsule. And so I know it's not only perfectly round and centered, but it's exactly 5.2 millimeters, which is important if I want to do an optic capture. Now here I'm using viscoat, a dispersive, to partially visco-dissect into the fornix, but I'm not going to rotate. So this just means that the epinucleus will be a little easier to remove. I do one horizontal chop, and then I try to pull in a heminucleus from either side. And again, once more, if I can avoid rotation, that's where I think it not only splits, but it causes a very gaping split in the posterior capsule. So I'm aspirating here just very patiently. But my point was really, these are cases where you can mentally rehearse the steps that you're going to take, because there are other times when you didn't anticipate it, and you just have to remember the principles of injecting viscoelastic. Now here, I'm doing the INA, and so far so good here. And it looks like I think I'm okay. But now I'm starting to see the posterior capsule is clear. And look at, there's material, there's debris behind the posterior capsule. So I'm going, uh-oh, that could be a zonular dialysis, or I could have a posterior capsule rent. You'll see that debris on the prehyaloid face. It's not vitreous rupture, vitreous prolapse. So I have to proceed very carefully, but at least I'm not going to come out, because my infusion is what pressurizes the anterior chamber. I've got a tight incision, but I've got to be very careful with the last bit of cortex here. So I'm ready to use, through my left hand, the viscoelastic to pressurize the anterior chamber. I go through my side port. I start injecting, and as I inject, I turn off the infusion, go to position 0. There it blocks it. Now I can see the rent very clearly now. And you see this little white opacity. I think that was the posterior polar opacity. So now what do I do? Because this patient wants an EDOF IOL. Can I put it in? It looks pretty rounded, but of course, it's going to split with any pressure right out to the periphery. So I put a little viscoelastic through the opening, push the hyaloid face back. This is an MST capsule forceps. We get it from Microsurgical Technologies. It's Barry Seibel's. And I'm trying to do the Brian Little capsule tear out rescue maneuver as I grasp this and pull sort of in this direction, because if I can round this off and create a posterior capsulorhexis, there it is, you see the opening here, then I believe I can put in a single piece with or without a toric, an EDOF, because I know I need to rotate this lens and position it in the visual axis for this to work well. So this is showing you the concept of the posterior CCC. You inject viscoelastic, something that will stay in place like a dispersive. And now I'm going to inflate the bag a little further. Oh, okay, I'm sorry. This was a T5 toric lens. But it's a high-power toric. And of course, I could do astigmatic keratotomy. I could do glasses, LASIK. But the patient needs a high power. I know I need to rotate it and position it. There's my Callisto marks. And so you can see that the posterior capsulotomy was very helpful here. It did not extend. It allowed me to place a premium lens. And in both of the last two cases, as you can appreciate, there was no need for a vitrectomy, because I was able to manage the posterior capsule rent without losing that, all right? Now, let's talk about when you have nucleus present and you have a posterior capsule rent. Now, here's a case where, oh, it's brunescent, and one of the things I'm looking at is excessive mobility or tilting of the nucleus. And what's happening is on my left, the entire bag has come loose. It's dehisced, it's tilting backward, and there's just no point in proceeding at this time. I could put in a capsule retractor, but it's just going to increase the likelihood of losing it. So I abandon my clear corneal temporal incision. I go superiorly. I make a larger manual incision and use a lens loop to retract that nucleus, because my goal now is to get the nucleus out with a zonular dialysis, a suspected PCR. And then I'm going to do an anterior vitrectomy. And with such a large incision, I think an anterior chamber IOL is perfectly fine. There's many different approaches we won't go into, but I've already made a decision. Now look at this. There's phacodenesis, a rock hard lens, and temporal clear cornea. And I start to get more of this nucleus out. There's the fracture. But when I start to see excessive deepening, it no longer rotates, a lot of tilting. And you'll actually see in this case, part of the nucleus starts to disappear under the iris. I've got to have a high suspicion that there's posterior capsule rupture of zonular dialysis, and I'm better off stopping, because the more I continue and the more fluid pressure I have, the more likely this will push this through. So I stop and I see what I've got. Let's prolapse this into the anterior chamber. Once I do that, I can remove one of the iris retractors superiorly, move to a different new superior incision. The temporal clear corneal incision will be self-sealing, and I'm just better off getting the nucleus out, doing the vitrectomy, putting in an anterior chamber lens, and not trying to be a hero in these situations. So converting to an extra cap is another skill you want to have, and you want to mentally rehearse how you need to do this and not wait until you have you're panicked and you have to immediately act on this. You can do it under topical. You can also do a subtenon lidocaine injection in the inferior fornix. I like to abandon the temporal clear corneal incision and make a fresh incision superiorly, and I cannot do bimanual expression. I have to use a lens loop. Now, here is a traumatic cataract with a large zonular dialysis. So I'm going to make sure I tamponade this with a dispersive viscoelastic. And, after my CCC, normally I would put in capsule retractors, but in this case, they're actually too long, and iris retractors are all I need to do to support that peripheral area. I'm going to, this is a younger patient. So again, remember, biaxial IA has the advantage of tight incisions, but also the fact that we can dissociate irrigation and aspiration. But I'm going to, again, tamponade the chamber before I come out, because I don't want to have vitreous prolapsing through the defect. And it's very interesting to see how the CTR works here. It expands in all 12 clock hours. And now when I put my three-piece lens in the bag, however, the entire lens is tipping backwards. It's like a door that's hinged on the right. It's swinging down, and I realize this is not going to support the lens. So I have to back up, and I do think that putting a three-piece lens in the sulcus and capturing the optic is another alternative to intracapsular fixation when you have a zonular dialysis or weak zonules. Yes, you can suture something to the sclera, but if you simply put this in the sulcus, that's fine. Here I'm pressing the optic down and capturing it, and I think I'm okay. Now, when I take the viscoelastic out, I look at the CTR. It has moved. And I'm a little worried, so I now put back the viscoelastic, and I've got to decide, well, what's going on? Why did that CTR move up there? And, the lens looks secure. It's not going anywhere. I bring down Myocol, and again, it doesn't completely come down. So this is the point where you have to wonder, well, what should I do? Do I have to worry about vitreous, or can we just leave it? It looks pretty clear. So, I'm from the San Francisco area, and we have a famous police officer named Inspector Harry Callahan. So I asked him what to do.
I know what you're thinking, Dr. Chang. Is there vitreous? Well, you have to ask yourself one question. Do you feel lucky? Well, do you?
All right. Well, that's one question. We also have an ophthalmologist. Our highest ranking ophthalmologist in government is Senator Rand Paul, who's in the U.S. Senate.
Well, Dr. Chang, if I was a Democrat, I think we just inject some Icol, cover it up with a patch, and go on home. But being a Republican, I think we ought to look for a solution. We ought to see if there's vitreous. We ought to inject some triamcinolone and get rid of the problem.
So triamcinolone is something we should all be aware of. And here I'm going to inject it. And I put this case in because I don't think any of us suspected this much vitreous prolapse coming through. And we'll come back and talk about what to do now. But if there's any question, triamcinolone to stain the vitreous is most helpful. Here's a case where I was doing the chop and suddenly the chamber deepened and the pupil almost widened and everything went backward. And so I stopped and I put on the camera and I started running it. Well, here again, a sudden deepening of the chamber means that there might be posterior capsule rupture, and that's what happens. So what do we do now? So when you suspect there's posterior capsule rupture and you still have the nucleus present, you have to think about stopping phaco and coming up with an alternative plan. And now is the time to mentally rehearse what to do. And it's difficult because you have a small pupil, you've got multiple fragments, and you are worried about keeping this nucleus from dropping downward. And that's your goal, is to get the nucleus out and to preserve the residual capsule. Now, if you look at the surgeon's view, it's very tempting to say, look, it looks okay. Maybe if I just go in and pluck the nucleus with my phaco tip, I can grab it and lift it into the anterior chamber and do an anterior chamber phaco. But what you have to realize is that this may be what you're having, what I show in the diagram, and that is a posterior chamber, posterior capsular rent. And the reason the pieces didn't drop is they're resting on the hyaloid face. And what's different is normally when you point the phaco tip down and you have an intact capsule, the pieces aren't going anywhere. The fluid stays in the bag, and you can buzz with ultrasound and prolapse or lollipop into the fragment and just spear it, and then like spearing a fish, and then lift the nucleus up into the anterior chamber. And we've done that before, and we say, hey, look down on your lower left. It looks like that's all I need to do. But think about it. If instead you have an open capsule like I've shown here, when you point this down, the infusion is going to be pointed downward. It's going to widen the rent. It's going to be directed into the vitreous, and it's going to rupture the hyaloid face. And as the minute I go to ultrasound or vacuum, instead of the nuclear pieces are going to be pushed away by the infusion because the posterior capsule isn't holding it. And if I chase it and go on ultrasound, I'm going to end up aspirating vitreous and even applying phaco to the vitreous. And that's why we get into trouble in these cases, is because we don't realize or don't have this mental picture that I'm showing you of what could be going on. And what is the single worst thing we can do as cataract surgeons? I guess, we could drop the nucleus, but that's not a big problem because that can be fished out. We could disinsert Decimase. Well, you can go back and do a DEMEC and fix it. So probably the worst thing we can do as a cataract surgeon in terms of surgery is to aspirate and phaco-vitreous, because that will cause a giant retinal tear. And when that retina detaches, it has a 50% chance of PVR. And despite excellent vitreoretinal surgery, the patient may go blind. So you never aspirate vitreous. So the concept of what I could do is I could stop and I could leave it. But if I want to proceed, I first go through the pars plana and I inject a little viscoelastic underneath. I try to lift those pieces into the anterior chamber. And again, if I have viscoelastic and I'm not aspirating and I'm not deep in the vitreous, I can hopefully do that without entangling vitreous. And then we have to think about the principles of an anterior vitrectomy. So first, we want to use a high cut rate, so we minimize vitreous retraction. And you always want to be able to visualize where the tip is. That means you cannot go too peripheral, but you also cannot go too posteriorly. You want to split infusion. And you can do any variety of chamber maintainers. Here I have a self-retaining cannula. You can do a pars plana infusion cannula, but for most of us that aren't, skilled at that, just put an AC maintainer and it frees up one hand. But basically, remember my earlier point, your infusion is not hydrating the vitreous and it's staying anterior. You want to know the difference between cut, infusion, cut, aspirate, or infusion, aspirate, cut, right? Because if you want to remove vitreous, you want infusion, cut, aspirate. But you can switch it if you want to then later on go out and remove cortex and use it more like an I&A instrument. Now, we'll talk about pars plana, but for sure, we don't want to put the vitrector through the phaco incision. Why? Well, first of all, you have a very steep angle of approach, especially with my case, a small pupil. It's going to be too small for the incision. We'll have a leaky incision, an unstable chamber. And of course, vitreous is going to then wash out through the incision. And what happens is as we start to aspirate or cut or lose more and more vitreous, it'll also remove any viscoelastic in the anterior chamber. And what happens if the viscoelastic and the vitreous are removed? What's going to hold these pieces up? Nothing. They're going to drop down. And that's when we see the pieces disappear. So remember that this is an anterior vitrectomy, not a posterior vitrectomy. We're just using the pars plana as our incision. The advantage of the pars plana is you get a tight incision with a stable chamber. You get a better angle of approach and better access. And we keep the vitreous away from the incision and away from the anterior chamber. It's drawn toward the vitreous cutter. And if I can fill the anterior chamber with viscoelastic, like I've done here, I don't remove it. And that's what's going to keep all the lens material anterior, and it will prevent it from dropping back as I remove the vitreous. And I call this the viscoelastic trap. And I've published this in my textbook as a strategy. So here's a diagram. You cannot differentiate clear vitreous from the viscoelastic, but I'm actually filling the anterior chamber all with viscoelastic. You use as much as you need, but you fill it because that is going to hold and support and suspend all the epinucleus and nucleus while you go after the vitreous. And then I'm going to come in through the pars plana, and my goal is to cut this band. And I can do that simply by keeping the cutter behind the iris. I don't need to come into the anterior chamber. As long as I cut all across this space behind the pupil, I will sever any bands as I've shown here. And once the vitreous is no longer connected to the vitreous base, any strands that are up here, I don't have to worry about aspirating them because they're not connected to the retina. So now I go after this with bimanual I&A. So remember, if you're doing this through the pars plana, it's an anterior vitrectomy. You are going to be visualizing the cutter. Use the side port. Remember that, yes, you can have retinal breaks where the sclerotomy is, so don't make this sclerotomy too tight. You use a disposable MVR blade. It should just slide right in. It can even be done under topical. You can supplement with Septinons with it if you want. And of course, all of these maneuvers are controversial. You have to respect the fact that you can create an occult tear. And if you're not comfortable yourself, have a vitreoretinal colleague examine the patient postoperatively. But no matter what you do, even if you go through the limbus and do a vitrectomy, you still have a patient that's at high risk for a retinal tear. You have to go over the symptoms with them of what they need to look out for. And if they see a shadow in the periphery, they have to report that right away. So here's the first case that we stopped with all that vitreous. So I have to push it aside so I can see the pupillary space. I go 3.5 millimeters back. It could be 3. When I go 3.5, it's because I'm coming in at an angle. I'm angling toward the back of where the lens would be. There you see my cutter. Now look, I'm behind the optic. The vitreous is in the anterior chamber, but the vitreous is still aspirated right through the rent, even though I'm behind the IOL. And that's because that's the advantage of the pars plana approach, is when I draw vitreous toward the cutter, I'm drawing it into the posterior segment, not bringing more and more up into the anterior segment. I usually use an 8-0 interrupted vicryl to close the sclerotomy. And there you see that CTR goes back where it was. This patient that I showed earlier is a patient, who has a small pupil and Flomax. And the first thing I do is I stop and I think about this picture here. I move in a different area. And now I'm superior. I mark 3.5 millimeters back. I aim toward the back of where the lens would be. I'm not aiming toward the optic nerve. So my entry is closer to 3 millimeters back. And now this is the viscoelastic injection and the posterior assisted levitation using my cannula. So this is what I'm showing here. And I'm just propping it up into the anterior chamber because I don't want to, the pupil is small. Now I'm superior. I remove one hook and I can remove this. I cannot use bimanual expression. Yes, you could do a manual SICS incision if you want, but I'm really not so worried about sutures, astigmatism. I just want to rescue this lens. I put viscoelastic above and below, and so I cushion the endothelium, but it's propped up, and then I go in with a lens loop. It has irrigation if I need it. I start coming out. If there's too much resistance, stop and make the incision larger. There's a tendency to push the nucleus up against the cornea to squeeze it out, but that's going to damage more endothelium. So I just make it a little larger, and it should just slide out because I don't want to have all this vitreous suddenly gushing out. Okay, and there's some epinucleus, but I'm not going to go after it because remember, there's vitreous now, and I want to put as little traction as possible. So here is the visco trap that I was talking about, right? Filling the anterior chamber because the viscoelastic that I'm showing in yellow in my diagram in the lower right is going to suspend all that epinucleus in place. So now I close down my incision, and now I'm ready to do the pars plana approach. You could go through the limbus, but because I've already made a pars plana sclerotomy, that's my choice here. Because why? By going through the limbus, I'm going to burp out more vitreous to the incision. I'm going to maybe lose the viscote, and then I'm going to have this material drop posteriorly. So here's the viscote pal. I lift everything up. I'm using viscoelastic to trap and suspend the material. And now I'm going in with the INA and aspirating. I have a second hand free. I'm just using a little Lester hook to mash the epinuclear particles in there. But you can see that by cutting the vitreous back, staying behind the pupil, I'm really working in dispersive viscoelastic. Here I'm pushing it up again. And you can go back and forth. At the very end, I'm going to do one final sweep with the vitrector after I let the pupil, and then I'll let the pupil come down. But you see how I'm always anterior, but behind, I'm not in the posterior segment deep. I'm not, I can still see with my microscope, but the vitrector stays behind the pupil at all times, okay? And here, once we clean up, we take out the hooks. I've got such a large incision that personally, I think an anterior chamber lens is quite easy at this point. And as long as the anterior chamber lens is well sized and it's not too large, it's not too small, and you just measure the white to white diameter, these eyes do very, very well. And we put in the Myocol and slide this over. And what I want to do is make sure I don't have a pupil peak. I don't have any capture. So I kind of lift on each haptic. And then here I did an iridectomy. If I had a smaller pupil, I could use the vitrector to do that. And I close with my 3-0 vicryl suture here. The literature will say, and the AAO just published their ophthalmic technology assessment that again showed that the literature supports that there is no superior one method. I'm going to show maybe, I think I'll skip this case. Now, it helps, I think, to take these instruments that you aren't using all the time and package them all together, because typically you're just not anticipating needing to do an anterior vitrectomy, and then it happens. And oh my gosh, now they have to open up the vitrector, they have to run around and get all these things. And then you say, I need scissors, I need a lens loop, I need bimanual INA, so as much of these that you can put together in one kit. So, Katina has packaged my favorite instruments together, and they call it the Chang Contingency Kit. But of course, you can buy them, you can use any instruments you want and make your own kit and just wrap them up separately. So the things I want to emphasize here are, if you suspect PCR, do not chase after the nucleus, okay? You must stop and reassess. And I think the reason that we chase after things is that we're all afraid of facing the patient afterwards. I mean, if you think about it, for a vitreoretinal surgeon, doing a vitrectomy and getting rid of the remaining nucleus is their easiest case. I mean, that's pretty much the easiest case they ever do. And they do very well as long as they're referred. So why do we treat a dropped nucleus as such a catastrophe? Because it isn't. And I think it's because we have to go tell the patient, and the patient's going to be upset, not only that they had a complication, but that they're going to need more surgery and have to see the vitreoretinal surgeon. And because we're afraid of that, we're thinking, boy, maybe I should just pluck the nucleus with the ultrasound and the phaco tip, and maybe I can get that last piece out and avoid that. But remember, the irrigation now is pointing downward. It expands the rent. It pushes the nucleus away from the tip and propels it toward there. And as it's moving away and you chase it and try to buzz it with ultrasound, you aspirate vitreous and could cause a giant retinal tear. One of these, I do think we all have this fear of having to talk to an angry patient. So, I was a part of this textbook. It's not really a textbook. It's a manual that Bob Osher and Jack Parker put together for SLAC. And I think it's worth talking about how do you talk to a patient when there is a complication. so that you comfort them. You can't pretend that they should be happy, so you can't expect them to be happy, but you can reassure them. You have to be patient. You have to be empathetic. That means you put yourself in their position and you tell them that I know how you're feeling. You have to explain things in a way that's understandable. You have to acknowledge, I understand that you are disappointed, that you're really worried now about what's going to happen, and that this is a terrible inconvenience. And you don't apologize as though you made a mistake. You just apologize that they're having this unexpected and unpleasant experience. Just like if my air flight is canceled due to bad weather, the people at the desk says, we're very sorry for the inconvenience. They're not apologizing that it's their fault. They're just saying, I'm sorry. And you have to explain to the patient what is going to happen next. And in this case, you can convey optimism about the prognosis. You can tell them that you're confident that they're still going to do well and that you managed it well. So a couple of things I say is, so what would I say? And I think this is something I talked earlier about mentally rehearsing. You can rehearse what you would say in a situation like this. If you really want to do it, role play and talk to your spouse and use your spouse as a pretend patient to model this. And you say, so what I do is I I finish the case. They bring the patient to the recovery area. I do my next case because I'm worried. I'm under stress. Now I'm going to be behind schedule. All the other patients are unhappy. How am I going to finish all the cases today? I just do the next case. And while I do the next case, I can relax a little bit and sort of catch my breath. I tell my staff, don't let this patient leave until I come out and talk to them and get their family there. After I do the next case, I go to the post-op area where the family is, and I say, well, this ended up being surprisingly much more complicated, and that's why it took longer. There's a little capsule that is around the cataract that we try to save to hold the lens, but it was very thin in your case, and early on in the case, the capsule split open. And at that point, I had to do my best to manage the eye and make sure that everything went well. And I was able to. But I'm going to need to check you today later in the office because I need to check your pressure. So I want you and your family to come back at the end of the day at 5:30. And I want to check you then, and we'll talk much more at that point about what's going to happen. So I'm basically postponing this difficult discussion until later in the day because I want to spend as much time as possible that very first time. You have to answer all their questions, and you can't do that when you have 5 more surgeries or 10 more surgeries to do. And not only that, the patient has no chance to, they have sedation, they won't remember things. And the family is so stunned that they don't even know what questions to ask. So it gives them a chance to think about their questions, and it gives you a chance. And then I always end up telling the patient, once these pieces drop through that opening, and I use the word split, there's certain, you don't want to say your posterior capsule ruptured. I mean, that makes it sound like the eye ruptured. I don't even say, the posterior capsule tore, because then the patient may think and start telling other people the doctor tore the posterior capsule. So I just say the posterior capsule split. And then I tell them, the piece that was down there, I thought to myself, oh, this is going to be very inconvenient for the patient. But the problem is I can't see well back there because I use a different viewing system than the retina specialist. The retina specialist is able to see the back half of the inside of the eye, which I cannot. And so I stopped myself and I said, if I were the patient, what would I want? And I decided if I were the patient, I would want Dr. Chang to stop and let some of the vitreous specialists get that last little piece, even though it would be more inconvenient and I need a second procedure. And I've never had anyone where I said, I stopped and I thought what I want if I were you, and this is what I did. No one will ever criticize you for doing what you would have done for yourself. Okay. So these are things that we don't necessarily get taught in our training. We learn it through experience. And this is kind of the way, I have learned things here. So remember that not everyone's comfortable going through the pars plana. You can still do it through the end. You can do an intravitrectomy through the limbus. You can stop at any point that you're not comfortable and just close up and go home and refer to a vitreoretinal specialist, because your goal is, I'm not going to, aspirate vitreous. If you are going to close, you'd like to clear the vitreous from the incision if possible, because it's going to put traction on. You can place an anterior chamber lens. You can place a posterior chamber lens if you have an intact rexus, or you can leave the eye aphakic, because it doesn't all have to be done at that time. And don't delay and don't hope and pray that everything's going to turn out well. Refer to a vitreoretinal surgeon. The textbooks that I have written talk to this. So all of my tips on advanced phaco techniques and how to deal with complications are in this book on the left. And on the right, we have 70 chapters on lens implantation. And this came out in 2019 in the absence of the posterior capsule. My last case I'm just going to show is this issue of posterior capsule rupture when you have a premium IOL. So here's a tough one. This woman was so happy because I did a multifocal in her other eye. She can't wait for the surgery in this eye. And I'm unhappy because there is a large rent in the posterior capsule here. And I know she's going to be upset. And I'm thinking to myself, concentrate, get the cortex out. But I can't stop thinking about how upset and angry she's going to be, because she has a multifocal in the other eye. And I see this large rent here. I'm not going to be able to turn that into a posterior CCC. So how am I going to, well, just concentrate now. And this is what you have to do. You have to forget about the patient being unhappy and concentrate, do your job. Don't aspirate vitreous, get the cortex out. So I have not, I'm just, okay, now I'm free. Now I'm going to put viscoelastic in. Now I'm going to reassess things. And what am I going to do? So I do have an intact rexus. I could put in a 3-piece multifocal lens, but I don't have any of those in my in my operating room. And look at how big that rent is. Okay, so there's no way I can convert that. But I don't. It doesn't look like I have any vitreous. So I'm going to put in it's a restore IOL, and I've put it through the opening. I'm going to put the entire lens through the capsula rexus because I have not lost vitreous. And once it's in there, I'm going to pop the optic upward anteriorly through the CCC. And this is called reverse optic capture. The haptics stay under the anterior capsule, so those sharp edges will not chafe the iris. The optic is sitting above the anterior capsule, but because the haptics are underneath, it can't move, and it's sort of pinned against the capsule. So it, interestingly, does not chafe the iris. And this is the one time you can have a single piece acrylic optic in the sulcus, and that is if the haptics are behind the anterior capsule, so-called reverse optic capture. Now, you're going to say, well, what about with a multifocal lens? What if the power is off? What if it's a little tilted? What if it's a little decentered? And my thinking was, if I was 56 and had a multifocal in one eye, give it a shot, and maybe it'll work. And if it doesn't work, I can always go in and take this out and put a monofocal in. But right then and there, and you see how here's the anterior capsule. I don't know, there's the posterior capsule rent, and then I'll highlight the anterior capsule edges right there. I can always go back and take this out, but right then and there, that's my one chance to do it. And in fact, this time it did work, and we were able to, she was actually quite happy with the final result. You see how you don't get an elliptical, you get sort of a box or a rectangular shape because of the broad optic haptic junction. And it centers the optic, prevents vitreous from coming through. You can cut the power by a quarter diopter, which means think about cutting the power only if it's a high-powered IOL. This is something to consider because, as I say, if you develop any issue with decentration, you can always take it out. You can do this with a toric. One final case, and then we'll stop for questions. Here I'm polishing my posterior capsule, and I made this rent here. And this is a patient that I was planning to do a symphony in. So now I have another large rent shown here. What can I do? So once more, I'm going to show doing the pars plana anterior vitrectomy one more time. Now I didn't use triamcinolone here. I don't think I need it. I have viscoat in the anterior chamber. And my goal here is by coming from behind, I'm not pulling vitreous through, so I'm not going to enlarge this opening any further because maybe I can do a posterior CCC. But in order to do that, I cannot pull vitreous through the opening. Once you pull vitreous through a posterior capsule rent, you will expand it all the way across. So now it didn't, you can see that even though I did the vitrectomy, the opening did not enlarge. And I'm tugging here, and I don't know how well across the globe in India you can see this, but here is the tear, and I'm tugging on it, and I'm rounding it off. Here's the tear right here where the cursor is. So that side is rounded off now, but here I have this big triangular flap, and I'm having trouble. How am I going to turn this into a posterior capsulotomy? It's rounded here, but it's stellate here. And I'm really trying to round it off, and I can't. So, so I put a little more viscoelastic in. One of the nice things about these forceps is I can turn them. So here you see where the rent is. I can turn the jaws so I can try to grasp the edge. And, I can rotate it. Plus, I don't burp viscoelastic out through the incision, so I don't lose my chamber. And so I can come at it with this approach, grab it here, and then I pull away from the direction. This is the Brian Little's idea or principle of putting it on stretch and then pulling it. And then actually, all of a sudden, it rounds off. And here it goes right here, and it rounds off, and I got it. So I've rounded it here, I've rounded it here, and now I think I can put a single piece in the, I'll finish this, put it in the bag, and whether it's a toric or an EDOF or a multifocal. Now I have a backup plan. I could have also done reverse optic capture as I just showed, but I wanted you to, because this is a unique thing, that first case of the posterior polar cataract where I had a PC rent, I put a 3-piece monofocal in the sulcus, captured the optic. That's a beautiful case. The patient sees well, they never need a YAG capsulotomy. But if, as in this is so often the case now, a young patient, we were going to put in a premium IOL, they're going to be so unhappy. So this day and age now, we're often challenged with how do we get our premium IOL in when there's been a posterior capsule rupture. And so these kinds of techniques are worth trying. And I emphasize, you can try it. And if it doesn't work out, you can exchange the lens later. But this is their only chance to have that IOL, because remember, after discussing it with you, you and they have already determined this is the best IOL for them. And that's why they become so disappointed and devastated if they can't do that. So again, there's my closure. You bring down the pupil with Myocol, don't go behind the optic, but you can see here that we've centered that case. So here was the rent up here before, and then here is the rounding it off. You can see how the rent didn't expand. And then I put the lens in and I brought the pupil down. So this patient ended up doing well, and then wanted her second eye done, which I was able to do, and she did very nicely. So these are the Cybele microforceps, and you can notice that I love them so much that I made the capsulotomy in the shape of a heart. So I've gone on for a little over 45 minutes. I will stop there so we can have some questions. And thank you for your attention. I really appreciate doing this format, because you just can't do as much in 10 or 15 minutes. And my goal was to kind of show the entire gamut of skills that we need to have to deal and manage with posterior capsule rupture. Thank you.
Thank you so much, Dr. David Chang, for sparing your time, for showing us those gamut of posterior capsular rents, for your Chang contingency kit, and for your slide on PCR, on which you spent, I think, the maximum amount of time. That is the counseling of a patient when one has PCR. So, and also for showing us the various ways in which multifocals can be put despite a rupture. So I think now it is open to discussion, and I would request first Dr. Mahipal Sachdev, who is the president of AIOS, to say a few words.
Thank you, David. Always a pleasure to hear you. You are one of the most expert surgeons we love to hear regarding cataract surgery, and phenomenal tips you always give as regard posterior capsular rupture. I think what you said rightly was to realize what is happening and to take corrective action from where things are. And also, you're saying that the posterior capsule is split is much more than somebody tore your capsule and things like that. I think that makes a lot of things. Unfortunately, patients have become less forgiving even in India, and they consider posterior capsular rent, which happens to the best of us, and specifically those who get these complicated cases, it's likely to happen in them, and they consider that it's negligence. So we need to be, the ophthalmologists need to be together in saying that even in the best of hands, posterior capsular rent does happen. That is something very, very important. And I think you showed all and various techniques as to how one should manage in different stages of posterior capsular rent. Thank you very much, Dr. David. And I think we can open ourselves to questions that have been posted by people. Or Arup, would you wish to take up any questions right from the beginning? And Dr. Titial?
Okay, so David, it was really nice. I mean, as usual, wonderful series of cases. I have a few questions which I thought could spring up in the minds of the audience. Now, regarding the posterior polar cataract, you have demonstrated a beautiful concept of using bimanual technique of irrigation aspiration of the cortex when there is an open posterior capsule. But what I have noticed that this may not always work in elderly patients who are in the 50s or 60s, when the vitreous is liquefied. Then, however much the principles of surgery that we follow, the anterior vitreous face may rupture. So that is something that I have noticed. But younger patients, and most of them come in at a very young age, in the 20s and 30s, this technique works out pretty well. The second question was, David, I saw you manipulate the nucleus with your left-hand instrument. Was it your Chang chopper, or was it something else which you used to pull the nucleus in a more accessible area?
Yeah, it was a good question. And it was the Chang chopper. It's whatever you would use for a horizontal chopper, because it can kind of hook the equator. And you're absolutely right. With a more denser nucleus, you still can try to chop it in situ. You put your chopper a little to the left and then you re-chop a little to the right. Um, and as soon as you can, you just lollipop into the heminucleus and try to bring it into the anterior chamber. Because in my experience, I have just found that rotating, whether it's an IOL or a nucleus, rotation, you're pushing against the capsule for counterfixation, and that's what really creates the wide split.
Okay. So I would a little different technique normally. If, I would debulk the central and the distal part of the nucleus so that it creates some additional space in the capsular bag. Then it becomes easy for me to mechanically dislodge or visco displacement of the subincisional lens matter into the more accessible central area for aspiration. So I think that was a very beautiful technique that we displayed. And then these complex and challenging cases, what kind of anesthesia do we use, David? Is it topical or would you like to use an injection anesthesia?
I think if you anticipate that you may need it, do a regional block, whether it's a retrobulbar or parabulbar, because you just don't want, on top of everything else, to have the patient moving and moving their eye, and the eye is, they're trying to close their eye, and you have a Bell's phenomena. But a couple of the cases, of course, were under topical. You weren't expecting it, and you can supplement with subtenons. But whenever you're dealing with, a potentially complicated case. Now, with a posterior polar cataract, most of the time, of course, you don't have a rent. So I typically don't there, unless, as you said, you have an older patient who has a posterior polar cataract and a much more denser nucleus, then I probably would do a block.
Okay.
Dr. Chityal, sir, would you like to comment on
Yeah,
the...
it was a wonderful display of skill, because I think the skills are required when you have difficult situations. And David, the teaching tips you gave to us was really would benefit our audience. I would just like to add, sometimes if you pick up your posterior capsular defect early, so we like to do in those cases where you still have a nucleus pieces there, people recommend doing a scaffold, intraocular lens scaffold, or people have used contact lenses also. And sometimes that can also, make things easier for surgeons so that the pieces don't go down. And surgery can be completed effectively in those situations also. What is your comment on that?
No, absolutely. Our colleague Amar Agarwal has certainly popularized that technique globally, and it's a terrific. So I showed sort of larger pieces coming out and converting. What I didn't show is sometimes you just have one piece left, and that's when the capsule tears. And so it's a really smart technique to put the lens in. You can put it in the anterior chamber. You can put it in the sulcus. You can even put it in the bag if you had a zonular dialysis. But what you're doing is blocking the vitreous from coming to the phaco tip and keeping things from falling. So usually it's going to be a three-piece monofocal that you're doing that with. So I'm glad you brought that up. It's an excellent point.
Other thing which normally I would tell my fellows, once you have a difficult situation and your PC rupture is large and you have done a lot of vitrectomy, if your anterior chamber is not, you feel is not effective for a implantation IOL, you can leave it for a case for a secondary implantation subsequently, maybe after 6 to 8 weeks. By the time you would know the outcome of a patient, you can plan your implantation better. And second important thing is once you have these patients where you have a PCR, you have done vitrectomy, the post-op medications and assessment is very critical in these cases. So next day you need to see your patients, and your counseling can also be effective at that particular time, the first day, and see for a periphery of retina, look for a long-term inflammation. CME can be much more in these cases. So those things are also important apart from managing intraoperatively these cases.
Excellent points. Excellent.
Otherwise, it was a wonderful videos, teaching videos. So we rarely have such, you can say impressive visibility of a PCR. Most cases are so difficult where you have PCR and difficult to record those cases also. Very nice, very clear videos.
Very clear videos coupled with the animations which were
Yeah,
shown, because
wonderful. That
between
was.
viscoelastic and vitreous, you can't make out what it is. So very nicely, actually, very nice teaching videos, David.
Can I ask a
You know,
question?
So,
one other.
Rajesh,
Go
would you want
ahead.
to ask something?
Yeah, it was a wonderful presentation, David, and thanks for your time. Actually, I just wanted to ask you one thing. A couple of the videos you showed that there's a PC tier, and you have planned for a monofocal lens, and you can round off and have a space wherein you can put a single piece lens in the bag. So, in what scenarios you would like to put a single piece lens and single piece lens in the bag, or reverse optic capture in which scenario, and multi-piece lens with an optic capture in which scenario? And do you think, is there any difference in the outcome with these different modalities of management?
So I think is an excellent question. There's a whole range of things where you have maybe a single radial tear in the anterior capsule. Okay, a single piece works out beautifully there. If you have a posterior CCC, you can put any lens in the bag. The problem with torics, with the diffractive optics, is we have to rotate the lens, get it into the right alignment. We try very hard with whether it's a Vivity or a Panoptics to, line it up with a visual axis. And so you don't always have that luxury if you've got a huge rent there, because it may not stay where you put it and it might not enlarge. So that's why either creating a posterior CCC or using reverse optic capture are helpful. But of course, for reverse optic capture, your anterior capsulotomy, it can't be too large, it can't be too small, and it has to be centered on the visual axis as well. I think my point before was, initially there's a part of us that says, you don't want to put a multifocal in or a Panoptics if everything isn't perfect. And that's generally true. But if you're in that situation, the patient's already decided on it, especially if they have it in the other eye. I think, again, if I were the patient, I would say, go ahead, try it, because that's my one chance. And if it doesn't work and I have, it's decentered, I'm having symptoms, we can always take it out and put another one back in. As Dr. Tityal said, if you're not sure, you can always leave the IA phakic and deal with it later. So I'm sort of saying you get a free chance to try it, and if it doesn't work, okay, fine, you're no worse off. But if it does work, then you had a rescue. So I think that's good. But, I think it's helpful to have a 3-piece monofocal there at all times anyway. And, Dr. Tityal just mentioned it's a reverse optic cap. It's an option for a scaffold. But I do think, again, telling the patient, I was able to get the lens in. Let's see how it goes. And telling them, I thought if this was my eye, what would I want at that moment? I'd want you to try, Dr. Chang. So I did that and I tried.
So, what percentage of your cases, you would have put multifocal and may have to, in the event of a PCR, and have exchanged it for a monofocal? I know it's
Yeah,
a uncomfortable question, but
that's an excellent question. So I can think of one. Fortunately, this doesn't come up enough that I have a big series. But I definitely had one patient where I did put in an EDOF. I think it was a Symphony. It didn't remain centered. I ended up taking out and putting a monofocal, I told the patient, I thought it was worth a try. And, if they understand, it certainly helps when you as a surgeon can do all of these things, if you can do an IOL exchange, because by keeping that patient with you, it becomes harder, doesn't it, when we have to refer them to another doctor to do things, and that's a little more disruptive. And I think something struck me when Dr. Tityal said you can always leave the patient aphakic. And one thing I didn't talk about is, what do you talk about with a patient before surgery when they have a rock hard lens or they have a posterior polar cataract and they're going to be complicated? How do you tell them? Well, you tell them that your case is going to be potentially much more difficult. And you want to have an experienced surgeon, you tell them, and you tell them, but there's a much more likelihood that the case could be complicated. And what does that mean? It doesn't mean you're going to go blind. It just means that the recovery may take longer. And in a case like yours, it might go really well and you'll see better after a week, but sometimes things happen and it may take up to 2 months for you to really, recover your vision fully from this case. And then you tell them, but you could have had this cataract done 5 years ago. You waited 5 extra years to do the cataract. It's no big deal. You're blind if it takes 2 months instead of 2 weeks. But you're, again, setting it up so that if they're aphakic, that patient's going to say, I can't see anything. And you're going to say, well, you have to wait 6 weeks before we can do more surgery. You've kind of already taken the pressure off yourself. You already told the patient it would take longer, So I think that's one way to put it. You're not scaring them like you have a 5% chance of blindness, because these are often one-eyed patients. That's why they waited so long to come and have their cataract done. But you're telling them the risk of these complications is just take a lot longer. And you don't have to go into all the details, And sometimes if people really push me, well, what could happen? What could happen? What could happen? I say, this is like telling you when you fly, there's a risk of complications. But I'm not talking here about the plane crash and everybody died on it. I'm talking about, okay, there's a delay in the flight and you got to your destination late. Or maybe you missed a connection. Maybe you even had to spend the night in the airport. Or maybe it took 5 days to get your luggage. Terribly inconvenient. Nobody's unhappy. Everybody says, why am I so unlucky? But at the end, you're going to forget about it because you got to your destination and it just made the experience less smooth. So you're putting it in a context because after all, most of these eyes will do fine. It's just that it's taking longer.
David, I have a question about the reverse optic capture. 2 questions actually. Number one, how easy or how difficult it is to obtain the reverse optic capture with respect to the single piece lenses from J&J or from Alcon? Number one. Second question was, you had co-authored a paper in JCRS in 2011, a white paper, that ASTRS Cataract Clinical Subcommittee, that single piece lenses should never be kept in the sulcus. So in these situations, you have such a thick optic anterior to the closer to the iris surface. So are you not really concerned about what happens and how do you manage those patients and what is your experience?
Superb question. So the number one reason for people to put a single piece acrylic in the sulcus is they don't have a backup 3-piece monofocal, And so even though it was well known at the time, we wrote that white paper and reported a bunch of retrospective cases from multiple practices because it was still happening. And the reason is that you have mobility. The lens will be too short in the sulcus. You have sharp edges, and that mobility combined with the sharp edges, particularly in the haptics, will chafe the iris. And it's a time bomb. It's just a matter of time before they get recurrent microhyphema, decentration of the lens, pigment dispersion, and glaucoma, and CME, or the UGG syndrome. With reverse optic capture, I think the difference is that the lens doesn't move. And in addition, when you put the haptics behind the CCC, it kind of holds the lens a little bit tighter against the anterior capsule. And I think that's why we don't get the UGG syndrome with that. We don't have a lot of experience collectively with this, but when you ask around, has anyone ever seen UGG with ROC? I'm not aware of that case. So I think your points are excellent. And you're going to do it mainly because the patient wants a premium lens. Same thing, if it happened, if you started to see transillumination or pigment dispersion, you can always take it out and put a 3-piece monofocal in that place. To your other question, the J&J material is stiffer, so it can be done. It's a little more difficult. It's definitely easier with the Acrosoft because that material is, even the edges, you can curl them up easier. So it's definitely harder with the J&J material, but it can be done, such as, say, if you were doing a Symphony or a Toric. But if I was doing a high-power Toric and I had to do ROC, I would choose the Acrosoft rather than the J&J, just because the material is softer and a little more flexible.
Dr. Partha? Yeah. You have to unmute yourself,
Yeah.
Dr. Partha.
Yes. So David, excellent lecture. You will keep learning from you all the time. Just one or two small questions that I had for you. The case in which you showed the opening up of the anterior segment incision, a large incision that you made and very well sutured at the end. So would you also consider giving it a frown C, something like an SICS incision, and taking out the nucleus? The number of sutures less, and the incision would cause maybe less astigmatism. So that was one query that I had for you. And the other one that I had for you is about the PCR. You showed those beautiful cases of the PCR, and of course, with the small PCR, of course, a rexis can be fashioned, and then it just behaves like a good bag, and you can put in the lens. But the one that you showed was very, very important, I think, because in a case in which there's a large PCR and you got that rexis in is very important. But at the same time, at times when you're pulling in the posterior capsular rexis, the zonules tend to crouch in, and then you have to have that balance where you must let go and not do the rexis, and where you can pull a little more and the rexis comes in. So I think, especially with the elderly and weak zonules or with a pseudo exfoliation, these things would be a little bit of matter of concern. The other thing that I just wanted to remark is when there's a very large PCR and there's vitreous in the anterior chamber, so the retraction of the PC with the vitreous itself is quite large. And then if a good vitrectomy is done, the PCR is not possibly as large as it looked in the first instance, because the flaps have come in, and at times you can still put in a single piece lens in the bag if there is at least 180 degrees off the support still existing. And thirdly, and of course, I really say kudos to you, the compassionate attitude with which one has to deal with a patient in whom a complication has been there is very, very important. I just call it 2 H's. That is honesty about what has gone wrong, and the other H is hand-holding. So I think both these coupled together, makes a satisfied patient at the end of the time.
Oh, I love that, 2 H's. That's honesty and handling. Yeah, that, and a great point. So the other 3 are excellent points. So on the conversion to the extra cap, I think at that point, that's kind of your kind of emergency rescue, and you do whatever you're comfortable with. So it might be a manual small incision with a scleral pocket incision with a funnel. It might be a frown incision. The thing to remember is that the eye is often soft, and so the scleral dissection is not the way it would be when you approach a virgin case. So I would say do what you're comfortable with. The other thing is, you're not going to be able to push and put as much pressure on the globe as you normally would, because you've got a zonular dialysis, posterior capsule rupture, you've got vitreous prolapse. So I think the most important thing is you want to be able to remove the nucleus in an atraumatic way. And because I think the more vitreous that gets incarcerated, the greater chance of retinal detachment. So as we balance those things, I would say astigmatism, number of sutures is a low priority, avoiding retinal detachment, retinal tear, high priority. So whatever you do, you don't want that incision too tight. You don't want to have to squeeze and push on the globe too much. And so, that for me is still a limbal incision. You get the most opening for the length, but I think there are many different approaches to that. The next question was with the, I forgot what your second question was.
The large PCR.
Oh, okay. I think the posterior capsulorhexis, I also look at that as a free opportunity, because the only thing, you might end up having to do a vitrectomy, but it's surprising, the patient's supine, and if you put viscoelastic in there, usually the hyaloid face is dropping backward. And so you actually have working space. And so I know that, 8 out of 10 people will say, I'm never going to touch that. That one is just too scary for me. But what's the worst thing that happens is it tears out to the periphery and you're back to using your anterior capsule to try to hold this. So I think it is something worth a try, but you're right. It's difficult. It's difficult because the posterior capsule is thin, like a pediatric anterior capsule. It has a lot of elasticity. That's why you have to use the little tear out rescue maneuver. And you brought up a great point about the zonules sometimes being deficient. You don't have good counter traction or counter fixation. So, it's something that you get to try. It's a real test of your capsulotomy skills. But if you're able to do it, it's a great rescue technique. So great question, great points.
So David, when you're bailing out from a phaco to a non-phaco technique, ECC or SICS, do you give a relaxing incision to the rhexis margin for safe delivery of the nucleus?
I think you have to, and I'm glad you brought that up. Yeah, I didn't make that point. You can convert it to, it depends how large the nucleus is. We all know that the CCC will stretch, but you make a nick, where right in front of the incision, if it's a CCC, or if it's a giant nucleus, you can make switch it to a can opener, if it's early in the case. You just, again, don't want resistance from the CCC or the incision, when you have an open capsule, especially when you may have vitreous there.
David, regarding your pars plana anterior vitrectomy, so I know you have been a big fan of this technique right from the beginning. And there are certain situations where there are certain logistic issues come up. For example, if you have an inferotemporal or superotemporal rem with vitreous going up to the periphery, to the paracentesis or to the section. And then you have a deep set eye, big nose and deep set eye. So it is very difficult to make a sclerotomy and access the areas of the vitreous. And sometimes I have seen, I have to resort to limbal bimanual vitrectomy for those cases. So pars plana anterior vitrectomy may not really work out in all kinds of scenarios.
I completely agree, and you're making a very good point. So I think that, access is one. I mean, sometimes if you're comfortable doing it with your left hand, you can get access by going in a different quadrant. And a lot of times we combine it, don't we? Because there is vitreous incarcerated in a paracentesis or something. So we do the bulk of the anterior vitrectomy through the pars plana, and then we come right back through the limbus to get the band that's caught in an incision. So it's really the combination. I think the main thing today is the principles. There's so many different scenarios, and if you understand the principles and the logic, then you can, employ that. There are cases where you have, there's no nucleus. Well, then it doesn't really matter so much. If you've already got the nucleus, the cataract is out, you tear it during the INA, it doesn't really matter then limbal or not. So I think the issue of pars plana becomes more important in two situations. One is when there's a lot of, nucleus perhaps present or lens material, and you're trying to keep it from falling backward. And that's that visco trap technique. And then the other is, when you have an IOL in place, as I showed that one case, that IOL acts like a valve. The vitreous is coming through the zonules, and you can pull it, but it won't fall back. And so that's where going from the posterior side and pulling it into the posterior chamber or the posterior segment works much better then.
So, Dr. Chityal sir, what would be your take? I mean, would you implant intraocular lenses in all PCRs, or would you rather leave some of them and do it at a later date? And then I would ask Dr. Rajesh, who does a lot of glue diols, if you were to do a glue diol, would you do it at the same setting or would you do it at a different setting, sir? Dr. Chityal sir first.
The answer is muted actually.
Sir, can you unmute yourself? Should I unmute?
Can you hear me?
I'm trying, it is not unmuted. Yes, yes, sir.
Yeah. I think we have discussed all the points. If possible, definitely like to put intraocular lens in these cases. There'll be a rare situation where it will be difficult to put intraocular lenses. In fact, if I see for last now almost a decade or so, the use of anterior chamber lenses have also gone down significantly because we can pick up PCR very early nowadays and safeguard the support of either anterior capsular access or a posterior capsule and implant the most effective lens, which David talked about, is 3-piece foldable lenses. In fact, I know that in Indian scenario, to get a AC lenses or anti-chamber lenses are difficult nowadays. Manufacturing is also difficult and inventory is also very less with us. So it is important to have a early detection of posterior capsular insult and safeguard subsequently and continue with the intraocular lenses. It will be very rare to have like situation like where we had a ectopia lentis type of cases, or we had cases with microphthalmos or colobopatous lenses, where things can be very difficult to assess on the table. That situation can be assessed. Otherwise, most cases would like to put intraocular lenses.
Uh, any uh, any great followers of posterior fixation of iris clip lenses?
As far as we are concerned, we are not comfortable. We
The
are not
panel
been
who's
trained.
sitting here is
No,
a.
no, that is why I'm asking, because there are a lot of
Actu-
people who do that, and they also claim it to be very good and giving great results.
Actually, I have removed a couple of, 6 disenclaved retrofixated IOLs, and then I have done a glue diol in that. So, even the risk of disenclavation is really high in these cases. So that's why we don't practice that. But then people who are used to it, they can do it. As far as glue diet is concerned, as Professor Tityal has mentioned, in majority of situations, we do get some rim wherein we can place the IOL in the multi-piece IOL in the sulcus. But if there is a bad, dialysis and wherein we don't have a proper sulcus, then in that case, a glue dial can be planned. It all depends on how much manipulation that has been done in the primary surgery. And if there is a lot of manipulation that has been done, it's always better to do a nice vitrectomy, leave the patient aphakic for some time, and maybe do a glue diol at a later sitting. But if there's not much of a manipulation done, then and the flap, etc., has been planned beforehand, as Professor Titialo was mentioning about in cases of ectopia lentis, then of course we can do it in the same sitting with good results.
So actually, being in a multidisciplinary institution, it always helps because you always have a posterior segment surgeon nearby, and a lot of times you can get away at the same sitting doing a glued IOL, because as you rightly said, sometimes the manipulation has been so excessive that the patient ends up with corneal edema, and you might have to postpone till the time that the inflammation and the edema settles down. So that is a big plus that at least I am blessed to have, and you people also, that you can call a retina person right at that particular time to do that, or if you develop your own skill sets to do that. So rightly said, I think more often than not we are able to handle it, but never feel shy, as David said, that even if you have to leave the patient aphakic for some time, you can do that, or you can call your retina colleague, but don't wish for a nucleus sinking or a piece sinking and cause irreversible or cause damage to the eye of the patient.
David, I mean, it is quite interesting that you showed that case of anterior chamber lens. So you also referred to two studies which came out recently in the ophthalmology technology assessment, and then 2003. I think the conclusions are the same. Right now, there is no evidence for any lens to prove superiority of any uh, lens used in aphakic situation or compromised zonular, capsular zonular situation over another type of lens. So I think AC lenses have picked up quite a bad name for unjustified reasons, but I think in selected cases, if handled properly, they do pretty well.
You know, I'm glad you said that because I think that, you know, when in meetings, what do we present? We present what's new, you know, and what we're excited about is doing things that are new. And so there are so many new approaches and we want to show that. But all of them will have complications if they're not done exactly correctly. And that includes AC lenses, it includes glued IOLs, Yamani technique. They all have complications. And I think for many of our colleagues that don't do a lot of referral cases, their one chance to do this is a primary cataract with posterior capsule rupture. And so, you know, I think it is important to say that there is no evidence that a scleral fixated posterior chamber lens is, you know, better than an anterior chamber lens in general. And people need to do what they're comfortable with. So I showed a couple cases where I already converted. I have a very large incision. And, you know, when you have an eye that is soft, most of these scleral fixated techniques, you want to have a firm eye, as we know. And so you need a chamber maintainer. And so in an eye that's you've already spent a lot of time in, the patient's restless, you've already done a vitrectomy, there's a higher chance of suprachoroidal hemorrhage, other things, sliding an anterior chamber lens in over the iris after you bring the pupil down with Myocal is very easy for people and under direct visualization. And we shouldn't really make people feel guilty about that like we do with a single piece acrylic. There, I think we all agree that that's a time bomb. A well-placed anterior chamber lens does extremely well. You know, the only time is if you need to do a DMEC or, you know, if you know that the patient will need something for their cornea, that would be different. And, you know, if you don't have the right size, that would be different. But, you know, I would not discourage someone from doing that. So I'm glad you echoed that.
Yeah. So
Yeah.
I think as
Yes.
cornea surgeons, we know that we are doing a lot of DMEX and we do it more for PCIOLs and complications and less often for ACIOLs, or maybe ACIOLs, you know, people are not putting, and that is the reason. But if we look at the cases of pseudophakic corneal edema, they are more for PCIOL and its complications rather than ACIOL. I just wanted to inform everybody we are having a record attendance today, despite the fact that it is 9:30 here in India. And on the YouTube, on the Facebook, and on our Zoom, there are many people watching, which was really not anticipated, but it's a record attendance today because I think of the panel and also because of, more importantly, because of David Chang.
No, it's all David.
I know, I thought as much, but then I thought let's acknowledge the panelists also.
No, I mean, this is an amazing panel because each of you could have done this type of class, and you know that you know All India Society has just amazing faculty, amazing teachers, and you know just like we do in the U.S. So it's a great service to your members to have these online gatherings.
So another interesting clear word that I picked up from David was PC split. So we have been talking to the patients about PC tear, PC rupture, and how traumatic it can be to the patient's sight. So I had picked up a similar clear words from some conference. When I have a vitreous disturbance, I don't tell the patient I have done vitrectomy. I tell the patient I have done vitreous enhancement. So patient thinks something has been enhanced and is very happy.
You did a floater removal. You did a floaterectomy.
Fluorectomy.
I saw some floaters and I decided, no. And then you did a prophylactic capsulotomy so they wouldn't need a YAG later on. No,
You know,
no,
many
but
people,
it is the words we use, you know, are important, and the patient's confused. And, you know, the first thing that's going to happen is their friend is going to say, well, what, you know, what happened? And then they're going to say, well, Dr. Chakrabarty said he tore my eye or he tore my capsule, you know.
the other excuses people have, would have given, your PC was very thin. So it had to be, it
Yeah.
had to rupture.
It could not
Some people
sustain the
say
eye.
you cuffed in between the surgery and you moved in between the surgery and it happened. And I remember one surgeon telling my assistant pushed me, my hand, and that created the PCI.
So, you know, it does bring up, you know, and I think there is honesty, but there's also looking at, you know, what it's like to be the patient. And I think that in all of these cases, do we really think that it was due to my incompetence that they had this? No. So I don't think I'm, you know, but I think that patients will be upset. They may be angry. At some point, they have to accept it and move on. It's just like mourning, you know, this is the stages of grief. And how do you get someone to accept something and kind of move on? Well, I think if they understand that there was a patient factor or circumstances that no one could have done better, then they can move on. If you say, you know, the nurse gave me the wrong instrument or someone hit my hand, that's hard to accept because they're going to say, well, why wasn't that prevented? Why couldn't have done that? You know, so you don't want to blame people and you don't want to shift blame because you're still in charge and the patient will still have. But if it's something that happened naturally, you know, we get cancer, it's nobody's fault, it's terrible, but we accept it. So when something happens and there's no fault of a person, it's actually easier for the patient to accept. And so I do think we're kind of helping the person through this grief process. There's the shock that it didn't go well. And then later on, there's the anger. Well, my friend didn't have this, and they went to this other doctor, or how come I had it? Whose fault is it? And I think we help them through that process by getting them past it's someone's fault. And whether you say, you know, there's these little fibers called zonules that hold your capsule and they're very weak. When the cataract gets really advanced, the capsule becomes more fragile and it can split at any time, you know. And then I always tell people, again, I had to think about, well, what would I do if I was the patient in that situation? And this is what I decided. Then the patient's reassured that you know, we're really thinking about them and they cannot be upset at you as the surgeon. So I think I'm so glad we're having this discussion because it's this fear of the patient that makes us do rash things out of fear and panic that we know we shouldn't do, you know, like putting a single piece in the sulcus or chasing after the nucleus. And, you know, and that's the fear that prevents us from wanting to refer them to a vitreoretinal surgeon. It's a great discussion.
The third case that you showed, David, that subluxated cataract. So I learned from somebody that, you know, and since then I have been following that technique is sideways soft shell, where you inject the viscoat towards the area of the zonular dialysis and then push in the Helon or Helon GV so that you have a wedge of the viscoat which sort of plugs that aphakic area. So that might perhaps prevent escape of vitreous in the subsequent stages of the surgery. What do you think about this?
Yeah, I like that technique. I actually haven't heard that because the dispersive spreads out and it stays where you put it, but it doesn't tamponade very well, you know, and so you're using the two different properties of those viscoelastics in combination. So that's a neat approach. I would probably say that the single most important thing is learned by manual INA, learned by manual anterior vitrectomy, and there are still people that try to do everything coaxial, and just being able to dissociate irrigation and aspiration when you have an open zonular or capsular defect is really valuable.
So I think if there are no questions, are there any? Rajesh, would you want to ask something?
No, it was a fantastic, discussion, a very good presentation. So thanks a lot for showing us some really challenging scenarios and solutions to those scenarios. Thanks a ton for sparing your valuable time.
Great. Well, it's great to see everybody. We're in trouble with COVID here in the United States, just like India, and I wish everybody well, stay healthy, and we'll get through it.
Yeah, you're in trouble with Trump too, right?
Really.
So, thank you, David, for spending your time to
All
be
right.
here. And I think we have another of your master classes scheduled for the 11th or 12th of December. We are trying to just sort that out. And
No problem.
we would like to have you again and again. And thank you very much for being there. We'd like to thank all the panelists, the chairpersons for being with us today. Our audiovisual team, I think we've had a large number of executive meetings today. So they have been busy since morning. And all the delegates and all the people who were watching it. And thank you for being there in such large numbers. So thank you once again. Thank you.
Thank you. Thank you, everyone. Thank you, David.
Good night.